लाइव स्ट्रीमिंग का। हाँ
ये आ गया ना।
तो हमें गाना पड़ेगा ना। हाँ मैडम, मैं आपको होस्ट बना देता हूँ ना।
जी सर, जी सर।
अभी आप हो ना होस्ट? अभी होस्ट आप हो ना मैडम?
हाँ जी, हाँ जी सर।
हाँ सुधा मैडम, अभी होस्ट आप हो ना?
हाँ सर, होस्ट में हूँ सर।
ओके, मैंने यूट्यूब लिंक पे आप दोनों के व्हाट्सएप शेयर कर दिया है,
जी
और जो इवेंट का जो व्हाट्सएप ग्रुप बनाया था ना उसमें भी शेयर कर दिया है।
जी जी सर।
अब बस एक पीपीटी शेयर करके रख देना जिसमें आपका ब्रोशर या कुछ है, तो यूट्यूब में भी वही दिखेगा, है ना?
हाँ सर, वो मैं लाइव कर देती हूँ अभी 11 बजे से।
चलो ओके, तो मैं निकलता हूँ ना।
हाँ सर, टेक केयर सर, सब बढ़िया निकलेगा,
ओके
टेंशन नहीं लेना।
ओके ओके, गुड विशेस।
ओके।
ओके।
जी सर, थैंक यू सर।
हाँ, एक
को होस्ट बनना आवाज आएगी वीडियो स्टार्ट वीडियो मेरा वाला ना कैमरा वाले म्यूट करो
हम्म 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 हम्म
हेलो हेलो उसमें कनेक्ट हुआ है।
Good morning, ma'am.
Yeah, good morning. Actually, I have I have collected in 2 of my laptops because one laptop there is some problem. So I just want to find out whether everything is okay. You can hear my voice, right?
Yes,
Yes,
ma'am.
ma'am. Yes, good morning, ma'am.
Yeah, good morning. Good morning. Just 1 second. Let me have the other one also.
Okay.
Hello, can you hear me?
Yes.
I think, but my video camera is not working. Some problem.
Ma'am, you can join from mobile also.
No, this is okay. But about my this one video, there is some problem.
And there is so much echo in your sound, ma'am.
Yeah, that's what I don't know what is wrong. Just 1 second. Can you hear me now? Hello?
Yes, ma'am.
As you can hear, probably camera, I don't know. There is some problem with the camera.
Ma'am,
Yeah, tell me.
Anyway, no problem. I don't know what is the actual problem with my camera. Otherwise, any voice is audible, huh?
Voice is audible, ma'am. Yes.
Hamsaka. Good
Yes.
morning, Hamsaka. Morning. Enda real Hamsaka. I don't know what is
Okay.
the problem.
Mm-hmm.
Is it because of YouTube or something? I don't know. Because usually when I on it, it will come. Maybe my camera is closed or what?
Maybe you can check, ma'am.
I will just leave and join. No problem.
Okay. No issues.
Good morning together is a beginning. Keeping together is a progress, and working together is a success. With these lines, I heartily wishing you a very warm good morning to one and all. It's a great pleasure to me to greet this. I extend my cheerful welcome to all the guests of honor, inaugural guest, our eminent speaker, respected dignitaries and country and movement of happiness for all yours presence. So move to the next part. For any new work, we recall our God and calling with the virtual lamp lighting.
Good morning, Dr. Subhan.
Am I audible? Hamsala, am I
Yes, ma'am.
audible? Okay. Video has some problem, no problem. Audible, it is okay.
Good morning, ma'am. Good morning, Mr. Hamsa.
Good morning, ma'am.
Good morning, ma'am.
Good morning, ma'am.
Good
Good
morning.
morning, sir.
Morning, ma'am.
I request to all participants to fill pre-test form. I request to all participants to fill pre-test form. A small cheer and great welcome make the merry fest with these lines. I invite our respected principal, Dr. Sudha Singh Mohe ma'am, to address our guest with welcome words.
Good
Ma'am,
morning.
you are muted.
Ma'am. Good morning. Did you hear me, ma'am? Good morning to all the respected guests, our eminent speakers and delegates who join us in this virtual platform. I am very much overwhelmed to organize this virtual national campaign in collaboration with NSS and DNIP Care. I, Dr. Sudha Singh Mohe, Principal and CEO of Sri Swami Samarth College of Nursing and Paramedical Sciences and Editor-in-Chief of Nursing Scholar Society, heartily welcomes to you all in our today's session. In this session, I heartily welcome to our inaugural guest, Dr. Piti Kaul ma'am, who took out your valuable time for us. Welcome, ma'am. I welcome our respected guest of honor, Mrs. Rita Sharma ma'am. Welcome, ma'am. I welcome to our guest of honor, Dr. Alka Tajne ma'am. Thank you for your valuable presence, ma'am. Welcome to our session. I also express my heartfelt gratitude to today's moderator, respected Mr. K.P. Hamza sir. I welcome our respected eminent speakers, Dr. Rakesh Garg sir. Welcome, sir. Alice Taylor Virginia ma'am. Welcome, ma'am. Dr. A.T. Kora ma'am. We welcome you, ma'am. And lastly, I welcome to all the program coordinator, Mr. Suresh, Secretary of Clinic Cares. Thank you and welcome, sir, for your presence. And last but not the least, I welcome you all the delegates and all the guests in our session. Thank you.
Thank you so much, ma'am. Success is not final failure. It's not fatal. It is the courage to continue that counts. With these lines, I'm going to introduce our great personality, Dr. Pity Cole, ma'am. PhD, Jamia Millia Islamia, New Delhi, 2004. Postgraduate Diploma in Distance Education, IG and OU, New Delhi, 1992. MSc, RAK College of Nursing, Delhi, University, 1988. MA Public Administration, Punjab University, Chandigarh, 1984. BSc Nursing, College of PGI, Chandigarh, Punjab University, 1982. She has total 40 years of teaching experience, additional experience, consulting in SOHS, IG and OU, New Delhi for 1 year, public health consultant, SIET, New Delhi, British ODA project, counselor, family counseling unit of service, New Delhi. I request ma'am to take her session on the topic. Inaugural speech.
Hello, good morning. Am I audible? Am I audible?
Yes, ma'am, you are audible. Yeah.
I'm audible. A very good morning to all of you. At the outset, I must express my immense. Am I audible? Am I audible?
Yes, ma'am, you are audible.
Yes, ma'am, you are audible, ma'am.
Off करिए mic को because lot of noise is coming in.
Please, participants, unmute yourself.
This is a lot of time. A very good morning to one and all. At the outset, I express immense gratitude to Nurse Scholar Society, the College of Nursing, Kiran ji, Suresh ji, Mukesh ji, and all who have given me this opportunity today. I would say that this topic or this area of discussion needs a lot of deliberations and discussions, because all of us know that this area of palliative care is going to put a greatest challenge and also is going to pose a threat in terms of the facilities to be provided by the healthcare providers to the palliative care personnel, and also it's also a challenge for the policymakers. It is also a challenge for the health system as a whole, because we all know there is an increase in LCDs, and these LCDs are going to pose a great threat to the mankind as it is on rise. We are also increasing the population, the elderly population, which will require the sustained care, and there are also some of the communicable disease which are coming and going, and they are posing a threat. So all this brand of promoting the care is mainly on nursing personnel. The nursing personnel not only cares but also improves the quality of life of such patients, and so they need to be well prepared to face this challenge. The government of India has gone in a long way to make the improvements in the quality care of people who need the palliative care. For example, there has been mention of this. There is a national palliative care policy as per National Health Policy 2017. This has also been made a part of Ayushman Bharat scheme, and there is also a budgetary allocation to the palliative care. And as per the recent data, it has been also found that there are around 108 institutions and 108 entities which are taking care, in addition to the other voluntary agencies, hospitals, how the homes, and also the clinics and other health facilities which are providing the care to the patients who need the palliative care. However, having said this, there is still a great need and there is a big way to go ahead for improving the care. We are still lagging behind. And if we take the stock and estimates of the statistics, we find that around 56.8 million people around the world need palliative care every year, and which will also include 25.7 million who are in the last year of their lives. So you can say how much huge amount of population requires the palliative care. But are we ready for that? I think we have all around the world, we have a long way to go to meet the needs of these people. If we talk about in India, we have 5.4 million people every year who require the palliative care. And you know how much only we are able to cater to the palliative care needs of the people who are having the terminal life diseases. Only 1% we are able to manage. And in the global level, we are only able to manage 14%. Only 14% of the people have accessibility around the world to the palliative care. You can see how much far behind we are. And similarly, as I have already said, the 1% of people in India. And if we take about the death index of India, India ranks 67th out of the 81 countries. So you can see how much far behind we are. So the brunt of this all, we have seen that how much forward we have to go in terms of health policy, in terms of health system, in terms of the health workers, making them available to take care of these people. We have to have, and more brunt of these services is on the nursing professional, because the focus of nursing professionals is on care and not the cure, because the nursing professionals have the more responsibility, the tremendous responsibility of taking this care, because this is the part of their job activity, because we are focused, our focus is on the nursing professionals, focus is on improvement of the quality of life. We all are aware that the palliative care is an comprehensive, and it is also a multidisciplinary, because the one person cannot manage this care. It's a multidisciplinary, it's a comprehensive, it's a holistic care approach, and which has more focus on social, physical, psychological, spiritual is more important. And also I can say that economical also, because most of the patients who cannot afford, and they have to be provided through insurances or through some other voluntary organizations. So economically they have to, that support, it is that support which you as a nurses have to provide. And we have also said that the cure is not the priority. In palliative care, the nursing professionals need to know that we have to focus on care in addition to the cure, because we do not have to withhold whatever the treatment a disease mandates, whatever the treatment, the disease we have to, the medical professionals have to prescribe. Alongside of that, you have to care. And where are we lacking behind? Are we as nursing professionals ready? I think we are not ready, because we have to have lot of researches to be done and prove with the evidences that what type of care is needed for the quality of life. We have been talking about quality of life, the evidence-based care since long now, but if we take the data from the India, we are very far behind in making any evidences regarding any of the care, not to speak of the palliative care. So the responsibility of this lies on the nursing professionals and the senior nurses who can handhold our future nurses to do the research, because the era is of research now. So the research has to be in the forefront of providing care to the patients who need the palliative care, because we know in our the curriculum is there in undergraduate programs in medical as well as nursing. Lot of courses are now being organized for palliative care, as you are also organizing this webinar. Similarly, some diploma, certificate, and the curriculum of undergraduate courses also address to the need of the palliative care, but that is not enough. The thing is that while we are on the job, we provide the care and find out the alternative, what is the best way of care. And in such situations, we focus that it's not only the treatment which we provide to the patients, but it is the patients we want to relieve the pain. We want to address to the breathing exercises. We want to address to the appetite of the patient. We want to address to the fatigue, depression, sadness, constipation, sleep. And these all are inbuilt in our nursing activities. So we have a still, when we talk about the initiative taken by the government of India, one of the most important initiative was that there was amendment of the Act of Narcotic Drugs and Psychotropic Substances, which was amended in 2014, because it made the restrictions were lifted on use of opioids like morphine, because they had proved to be relieving giving some relief or relieving the pain of such patients who are at the end of the life, or who are with the grave illnesses, and where the treatments are not taking the result, giving the results. So the scope, if we talk about the scope, then the scope of the palliative care services in India is in the areas like education, training, research, and patient care. And if we talk about the concept of primary palliative care, it will start from the grassroots level, where the cases could be identified by the ASHA workers, multipurpose health workers, volunteers, and community health officers. And we also are aware that these services can be provided either at home, they can be provided at primary health center, they can be provided at outpatient care facility, or the patients can also be referred, as the case may be, depending upon the condition of the patient, to the secondary level of care, to the sub-district hospitals, and to the subdivision hospitals, and also for the tertiary care. So if we talk about these functions, what at the various levels of care, maybe primary, secondary, and tertiary level, and we as a nurses have to be very prepared for this. And in whatever way, at all levels where we are working, we have to promote the education and the skill part of how we can manage that. Behavioral change, communication is one of the most important areas where we can focus on when we are talking to the patient, because it's not the patient, it is most importantly the caregiver, which is more affected, and which has more problems because he also suffers from various situations of home, health, family, children, and then they have to take the care of these types of patients. So it is these the nursing, I think the nursing has a tremendous role to play. And if we talk of the future, this has become now and emerged as one of the important dominant clinical specialties, and it is indeed high time for the palliative care services in India to expand their realm by focusing on a robust evidence-based approach, finding their way to all education. So I think with these words, I will wish you all the best, and request and impress upon all that we must do something on as a nursing professionals. We can have the collaborative thing, and then we can start a program on practical based palliative care, because we have been talking since the day we entered in the nursing. We are well versed with the terminology like palliative care, but we have not been able to make a dent so far as the illnesses go, so far as the terminal illnesses go, so far as the care which we provide, because we have not been able to supplement our care with mostly with the evidences what we do, because what we do is itself an evidence. When we do the care, when we provide the care, maybe in a maybe in sickness and wellness or severe illness as mandated in the palliative care, we can identify by working with open eyes. We can identify what is that best which we can do, what is the best way of doing the things. If the two patients, if you take care of two patients and then you find that the difference in prognosis of the two patients varies, it differences, that should give you an idea that how can I individualize care, and that individualization of care has to be based on the evidences. We cannot talk. We have been till now talking, but we cannot talk. We have to show the figures and facts, that if we do a care this way and if we do care in another way, what is the difference between two, and which one is the best, and which one is going on to give more results, and carry on making and developing and finding out more evidences. So all the very best to your deliberations. Thank you very much once again for providing me this opportunity to share with some few thoughts with you. Thank you.
Thank you, ma'am, for your valuable presence in your busy schedule.
फिर वीडियो चालू नहीं हो जाए यार, किधर किसी को क्लिक कर दे, डबल क्लिक कर दे बेटा। करना है इसको।
Every nurse was drawn to nursing because of her desire to care, to serve, and to help. And these lines are worth to a great nursing icon to whom I am going to introduce respected Mrs. Rita Sharma ma'am, Chief Nursing Officer, AIMS Rishikesh. Mrs. Rita Sharma ma'am, after completing GNM, joined at Northern Railway Central Hospital, Delhi as a staff nurse in 1995, completed BSc Nursing, PB, Diploma in Nursing Administration, Certificate in Healthcare Waste Management, Certificate in HIV and Family Education, Disaster Management, MA in Public Administration, MSc in Pediatric Nursing, etc. Working in AIMS Rishikesh as Chief Nursing Officer since June 2022. I request ma'am to respect it, ma'am, to address our guests and delegates.
Good morning, all of you. Am I audible?
Yes, ma'am.
Okay. Good morning to all the dignitaries, distinguished guests, speakers, and all the nursing students and staff who are present in this virtual national campaign on palliative care and update. I would like to thank the whole team of Shri Swami Samrat College of Nursing and Paramedical Sciences, Harda, in association with Nursing Scholar Society and DNIP Care, organizing the virtual national campaign on palliative care and update, a sensitization program for nursing fraternity. I would like to extend the warm welcome of Dr. P.T. Kaur, Dean, Faculty of Nursing, SET University, Gurugram, and former Director, SOH IGNOU. I would like to welcome our Secretary NSS, Dr. Alka Tajne, Principal, Vibrant Nursing College, Surat. Thank you very much for giving me the opportunity to be the part of this palliative care program. So we're talking about the palliative care. What's the meaning of the palliative care? Meaning of the palliative care to focus on alleviating and reducing the intensity of symptoms of disease. As we all know, the palliative care can improve the quality of life, comfort, resilience of serious ill patients, as well as their families. Seriously ill patients are those with the life-threatening medical conditions like cancer, organ failure, or dementia that negativity impact the patient's daily life or result in a high level of stress for the caregiver. As a number of the required such a type of care day by day increasing. So as the ma'am already said, Dr. Pitikor ma'am already said, only the 1% of the India population can access the palliative care. So there is such a huge gap in the care aspect as per requirement. So there are the program of the National Palliative Care Plan and the budget allocation, all the things are there, but still we are far behind to provide the care aspect to these required patients. So what's the benefit of palliative care to the patient? So put the patient desired goal and decision first as per the patient requirement and need. Support the patient and the family as during this such a long chronic illnesses, the patient is suffering, but along that the patient's family also suffered. So we need to give them holistic approach, multidisciplinary approach care. So help the patient family understand patient as per that. That's why in that way we can improve the quality of life of the patient and their family and relatives and other people. Provide the pain and symptom control. Focus on body, mind, and spirit. So we can't give it this as a alone. We have to work in a team. In a team, nursing personnel, other dietitian, pharmacists, for the psychological support, counselor, and all the people we have a need to provide the complete care. So our main care concept is to daily living care, social and psychological and spiritual need to be fulfilled of the such patients. Reduce the unnecessary hospital visit because these types of patients usually require the long-term care. So if they went to the hospital, the cost of definitely will be increased for the patient and their family. So there is a lot of difficulty to financially to these type of patients and their family. So the main purpose of the palliative care is to reduce the cost also, along with the care aspect. So palliative care is important because it gives patients an option for the pain and symptom management and higher quality of care while still pursuing curative measures. When a patient is seriously ill, they understand the value of each day while they still must face their illness. The support of palliative care in controlling pain and other symptoms can make each day a more positive experience that allows the patient to make the most of the time they have with their dear ones. So we have to focus on the evidence-based practices need to be implemented on the care aspect, which we could inculcate only through the research aspect also. So provide the care to these patients who are really terminally ill, sick, and the chronically ill, and the expenditure and financial burden on these families are more and more. To reduce these expenses, nurses can play the very important role in the palliative care. So that's why we are organizing this type of program for the care. Our nurses has to put their care with their hands and put their soul during the care of these such patients to maintain their life, quality life, and to live with the dignity. With these words, I would like to conclude. Thank you very much, whole organizing team, organizing chairperson, Mr. K.V. Hamza, General Secretary, DNIP Care, Mr. Suresh TP, Secretary, DNIP Care, and the Nursing Scholar Society, all the team. Thank you very much for giving me the opportunity to be the part of such a program of the palliative care. Thank you very much.
Thank you so much, ma'am, for your valuable and beautiful words. Our leader is one who knows the way, goes the way, shows the way. And these qualities found in the person who is a present between us. And our guest of honor, respected Dr. Alka Tajne ma'am. Dr. Alka ma'am completed her PhD in 2021 for Malvanchal University, Indore. She is currently working as Professor Principal of Vibrant Nursing College since 2018. She has taken 8 membership various society. She is Secretary of Nursing Scholar Society of National. She is registered as Inspector in Gujarat Nursing Council and India Nursing Council University. She has 22 years of experience in teaching and clinical. She has published numerous and research articles and working on many books writing projects. Dr. Alka ma'am received Best Staff Nurse Award, Best Teacher Award, and Best Professor and Award recently from UIGIR Journal. I request ma'am to say some words from our audience.
Good morning. Am I audible? Am I audible?
Yes, ma'am, you are audible.
Good morning, all the dignitaries, principal, and dear participants. It's my honor and privilege, and I'm happy to meet you again. DNIP Care, which is having a campaign mission, this is palliative care, and they are organizing various conferences in the national wide. So last conference I was promised to Suresh Tipi sir, and I told we will do conferences in our all the chapters in NSS. So thank you so much, sir, that you have given me an opportunity again. Today, I'm very happy to share this. Our Nursing Scholar Society was opened 28 December in 2021. And today is the second anniversary of Nursing Scholar Society. We are eventually we are opening various chapters, and there is a induction ceremonies are every month in the last date of every month. So our mission, our vision is care to caregiver. With this mission only, we are finding various nursing personalities worldwide, and we are felicitating them every induction ceremony. So thank you to Dr. Swaresh Khanna ma'am, and thank you our President, National President, Dr. Vinu Jo sir, so taking this society part. Now, coming to a palliative care, Madam Pitikol and Madam Rita Sharma, they have elaborated a lot, and our eminent speaker will speak. So I just want to tell a few words. Palliative care, this is a interdisciplinary medical caregiving approach, and it's a medical care for people, those who are critically, those who are having a serious illness like cancer or the heart failure. There are so many studies, what we have seen, we are reading, and we are doing also. So this palliative care significantly improve the patient quality of life and lower the symptom burden. Apart from being the right thing to do for patient, this is improve thing to do for a quality of life. Also means that it is an encounter with the health care system, and it's a less stressful and traumatic for the family member also and the patient also. So when we are thinking about the palliative care, we our word or our care or our touch only, which will give a patient a soothing effect. So last conference also, I told the same thing. Be a sensitive about your patient, and not only the patient, about their family also. So when we are thinking this, there is a lots of burden on the nurses, and we will see in a government sector and the private sector also, there is a lack of nurses. We have to maintain a ratio, but it's not maintained. But Pitikol madam is told, we know our India is so far in this. So if the burden will be reduced, then I think this palliative care we will achieve. But it will take a time. But then also, when we have taken this oath and we have thinking like we will do a best care, we give a best care. So we have to give a care and be a sensitive to our patient. So all very detailed. Other speakers, our speaker will be explained. So I will not go far away. Telling about the Swami Samarth College of Nursing, which is a new college, and within a less time they have achieved so many things. The credit goes to Dr. Sudha Singh Mohe and Dr. Arjun sir. They are working 24/7. And last week I went college as a chief guest in the lamplighting ceremony. I have seen a tremendous changes and so many things we have done. So best of luck. The college will be go very higher and higher, and they will open a more courses. So thank you to giving me this opportunity. Thank you, Hamda sir, and thank you, Suresh Tikki sir. We'll do more conferences. We will attach some more colleges also. Not only Nursing Scholar Society, but the colleges which is I'm going for inspection or which those are near to me. Or we can say I know the colleges where I'll contact the principal, and I'll be a part as a I'm also not to be for this mission of yours campaign on palliative care. Thank you so much, sir. Thank you once again. Over to you, madam.
Thank you so much, ma'am. Palliative care, when you feel the pain of others and try our best to treat every broken aspect of a sufferer, not a patient. Yes, palliative care is an excellent combination of expert professional care and truly loving consideration. So, to reflect these expert knowledge, I am going to start the scientific session by introducing the respected Journal Secretary of DNIP Care, Mr. K.B. Hamza sir, retired as Senior Accounts Officer, Ministry of Finance, Government of India, graduated from Kerala, working as a palliative care volunteer and Journal Secretary, DNIP Care, a registered volunteer group for palliative since 2008. Sir is a volunteer, took session on palliative care in many places, including University of California, Riverside, USA. Sir received KMCC Social Service Award. Over to you, sir.
A very good morning, ma'am. And good morning to everybody. Thank you very much, ma'am, for introduction. I think the screen sharing can be removed now. Now, it is a scientific session. So we have got eminent personalities of palliative care here to talk about the nitty-gritties of palliative care. Before that, I would like to comment on or comprehend whatever our dignitaries have already talked about. Dr. P.T. Kaul ma'am, it was really a detailed presentation about the palliative care requirement. It as a challenge that ma'am has depicted it. And of course, the current scenario of the communicable diseases, off and on, it is there with us. So nurses, ma'am says, of course, nurses have to face the brunt of these challenges. Definitely, ma'am. Yes, nurses. And I always say that nurses are there when the first breath is taken, and nurses are there when the last breath is taken. So nurses are not only to bear the brunt of these challenges, but they are there in the entire human life, and their role and services, that is really what we can say, it is godly, along with the doctors. And ma'am has also talked about national palliative care policy, healthcare policy, and about the institutions, around 108 institutions here. She talked about that it is doing the palliative care, having the palliative care setup, and apart from the various innumerable organizations working in this field, especially the NGOs. And then ma'am said that there is a 14% coverage in the world for the palliative care, and when it comes to India, it is hardly 1%, and that is a really dismal situation, ma'am. Yes, and it is the focus on care along with cure protocols that is there, because though it starts with the simultaneously, but at a little lower grade or meter, the palliative care, but the disease progresses, the role of palliative care also increases, and at the end of life, the palliative care emerges as the major, having a major role. And of course, NDPS Act and 2014 amendment has made little leeway, but not all, ma'am. It is still there are issues. And it's not available. The required pain management techniques, pain management medicines, all are not available, including the tramadol has also been put under the category of scheduled drugs now, that it cannot be simply given. And ma'am, it was really nice hearing you, your presentation. And thereafter, Rita Sharma ma'am and Alkata Tazne ma'am, Dr. Alkata Tazne ma'am, they have also talked about the details of the requirements, and how the touch can be given, which will be a soothing effect for the patients as well as their families. And Rita Sharma ma'am has emphasized on the point that there is a huge gap between the requirement, demand, and the resources, and that meeting that gap or filling that gap is really a challenge before all of us, the medical professionals, and we people, just like I'm not a totally medical professional, but a common man, and we are also trying to fill in the gap in whatever way we can. Just like the Gileri of Ram, he also used to help in building the Ram Setu. And so whatever he just rolls on the mud and puts the mud on the sea for making the bridge. So that way, even everybody, every individual has the responsibility, that is the individual social responsibility, for providing the service for the human beings as their duty, and as their requirement from all of them. So I'm not to do much of these things, because our eminent personalities are there, and I think the introduction will be given about the speakers by you, ma'am, isn't it? The
Yes, sir. Yes, sir.
Okay. So I'm
Yeah,
not
yeah.
getting into the introduction of them, but definitely the first one, sir, is Dr. Rakesh Garg, sir. He is to talk about introduction and need of palliative care. Yes, he is an expert in the matter, and we are really grateful to him for his unconditional support to the propagation of palliative care among the masses, and that includes the nursing fraternity as well. So we are really thankful to him, and I would request ma'am to please introduce him, and we can give him the floor. Please, ma'am.
Meanwhile, if you can allow me to share the screen also. Thank you, Dr. Amja. Mr. Amja.
Thank you.
Thank you, sir, for your motivating words. That moment is always best one in which to express our care for others. And with these lines, I am going to introduce the person with great medical knowledge and expert, respected Dr. Rakesh Garg sir, additional Professor IRCH, AIMS, Delhi. In present position and institution, sir, is additional professional anesthesiology and critical care, pain and palliative medicine, Dr. BRAIRCH at All India Institute of Medical Science, New Delhi, India. He had publications total of over 250 publications, internationals and national, author, 25 chapters in books, editor of 2 books. He is elected as council member for ISSP, Indian Society for Study of Pain, Delhi chapter. He is governing council, executive member, Research Society of Anesthesiology, Clinical Pharmacology, RSACP year 2018-2021. He is Vice President, All India Difficult Airway Association AIDAA 2019-2021. He is life member of our 20 national and international professional bodies. I request sir to take this session and give his knowledge with us. Over to you, sir.
Thank you so much. Thank you so much, ma'am. If you can allow me to share the screen, please.
So you can share now your screen.
It is showing a host disabled participant screen sharing, madam.
Okay, sir.
You need to make me co-host before I can share, ma'am.
Okay, sir. So you can share now.
Okay, thank you. Thank you. Is my screen visible?
Yes, sir.
Thank you. Thank you so much. Thank you, Hamzaji, for inviting me today for this nice interaction on the introduction to the palliative care. This is why I think the discuss here because that is under the basic concept of. So maybe next minute past, we'll be discussing about what is palliative care, what's need, and how can we take it forward. So when we talk about the palliative care, let's see this patient, 35-year-old man presented with metastatic cancer pancreas, metastasis to peritoneal, and now he's having severe abdominal pain, ready to unable to lie down. Now, majority time when these patients go to a hospital, we usually talk about the diseased focused care. We will be looking for what the disease is and how can we manage it. But what we need to understand is that at times there will be disease which may not be possible to get cured, because if you see this patient, he is having metastatic disease in spite of treatment. So we need to provide him a comfort care. And although if the curable, the chronic diseases, I take you to the disease a little later, they will also require some amount of supportive care so that these patients remains comfortable. And this is the lady who started the palliative care, the movement of palliative care, Dame Cicely Saunders. And she is the founder of whatever the events are happening in the palliative care. And what we need to understand is, if we see in India, almost 3/4 of patients would come into advanced stages. Their disease may not be fully curable upfront, and they would require certain treatment, and they will be having certain symptomatology. wherein we need to mention those symptom management and give them comfort care. So this is a huge number, and that is why the need of palliative care is emerging to a very large extent, not only across the world, but in India also. And this is the classic definition of palliative care. We talk about holistic management of a patient to improve their quality of life and the family's life also. Now, when we see these patients of different chronic disease, they will have a different trajectory of their life and finally to death. For example, say, let's see the patients with cancer. They will have, if the cancer becomes metastatic, they will have decreased downwards. But if you see the other chronic disease like heart, lung, in those situations, there will be some amount of deteriorations in the phase of life of these patients because of the acute exacerbation of the organ failure, and finally they succumb to death. If you talk about the neurological disease, they will gradually succumb to death, and there will be gradual decline in the functionality of these patients. So understanding this is important because these patients would come to a palliative care team in the various phases of life, and it becomes important to give them some amount of comfort care so that these patients has a good quality of life. And if you see who are these patients we are talking about, they can be any patients, the oncology patients, the other chronic disease like AIDS, neurological disease like the cerebrovascular accident, the Alzheimer's, the multiple sclerosis, motor neuron disease. So these are all diseases which would require some support system as a part of comfort care, as a part of palliative care to these patients. And hence, we should be ready to provide palliation to these patients so that they can live a decent, good quality life. And the numbers are increasing. Whatever disease you talk cancers, you talk about HIVs, you talk about renal failure, you talk about heart failure, you talk about kidney failures. The number of patients are increasing, which requires their support system. And this symptom management, majority of time, we'll be talking mostly about the physical symptoms like pain in the body, like vomiting, respiratory discomfort, decreased urinary output. But we try to ignore other symptoms which are very important or equally important, which include the social, emotional, and spiritual problems also. So in a palliative care setting, these are the important things that we should also try to incorporate into the patient care, holistic care, which includes the physical, social, emotional, and spiritual problems. Now, these are the various concerns that are seen in palliative care. These are primarily located to the physical symptoms of the patients, which we require as a part of palliative care management. But we should be very clear that other holistic management, including the psychological, social, spiritual, and preparing them for a good death is the approach for palliative management in any patients with chronic disease. And in India especially, it is patient-centric, family-centric. And hence we need to include the family also in decision-making so that these patients remains as a part of a unit of a family. And hence what I mentioned, when you talk about palliative care, it is multidisciplinary, it is interdisciplinary, it's transdisciplinary. This means we will require various involvement of various people, and the nursing professionals remains one of the core team member because they will be involved with each of them. Whether we talk about the palliative care physician, whether talk about home care, whether talk about dietitian, counseling, whether understanding, whether to just give them moral support, whether to give them the routine cares. So they have involvement into all those things. And this is what interdisciplinary approach is required to give them a good physical, social, psychological, and spiritual supports. And hence, we need to have a team which will provide this support system. And that's the beauty of the palliative care, where we have a team where each component of the patient concern is being taken care by the individual, and the patient is get supported as a holistic approach and preventing them a total suffering. And this is what I mentioned about total suffering. Total suffering means just not the taking care of physical, but also psychological, social, spiritual, and emotional. And you can see that various people are involved in caring these persons for the various symptomatology that these patients have. Now, we also need to understand that the patient is, in Indian scenario, is very well supported by family members, the close relatives and friends, and they are also incorporated. So they have also an impact on their care. And hence we usually consider these patients as a unit of family where we try giving them care to prevent this suffering or taking care of the total pain of this patient's management. Now, sometimes it is believed that the palliative care is only for those patients who are terminally ill. No, this is not true. When I said that patient who are having chronic disease, they will be getting some treatment, some follow-up, and they will be suffering from various aspects. For example, when a patient is diagnosed with cancer, and that stigma of cancer or stigma of AIDS will cause a lot of psychological issues in these patients. They may have financial issues also. So that's why these patients would require palliative support even at the initial diagnostic phase also. So this means palliative care is just not the hospice. Hospice is, yes, the terminally ill patients management, but the palliative care includes the early management. And that's why if we say that palliative care nowadays is an early integration into a patients who are diagnosed with chronic disease. And this is what we understand is that, yes, modern medicine, we need to take care of it. Hospice is for terminally ill, but palliative care encompasses all those aspects. Now, what exactly remains the basic principles of palliative care? As I mentioned, it has to provide a good physical symptomatology, comfort care to these patients. It affirms life. It enthusiasms energy into the patients, and the acceptability to disease, the disease progression and the death is to be accepted by the patient and the family members. Sometimes people think that palliative care is to hasten death. No, this is not to hasten death. This is to just provide them comfort care so that whatever time is left with them, they can live a comfortable life, ending into a good death. And I'll come with what do you mean by good death. It integrates the various aspects, the physical symptoms, and also the psychological and spiritual and emotional systems of it. And that requires integration of various support systems, including the family. And this is what we have a team approach in managing these patients as a total pain, right? And this enhances the quality of life. And this enhances probably leading to a good death and better acceptability into the patient family members. So if the family members see their patients who are crying in pain or they are in agony at their endpoint and life, they also have a huge impact on their psychological understanding once the patient dies. So that's why we have to not only enhances the quality of life, but needs to provide some amount of brilliant support with the family members, to the family members, by providing good care of our terminally ill patients. And as I mentioned, the chronic disease, the patient will have, I showed you the initially the trajectories. These patients will have variable symptomatology, and hence palliative care needs to be integrated early in any patients with chronic disease so that they can be taken care of. Now, as I said, the palliative care is an early integration into patients with chronic disease. But then if the patient is not responding to treatment well, they will have a terminal illness. And what we need to understand is to provide them a comfortable death or a good death. And that is what is end-of-life care. And this may be for patients who are bedbound, semi-comatose, they may not be able to eat properly, they may not be able to take medication, they may not be able to take self-care. And there will be many such symptoms also which these patients will be having. And this is what the symptoms of palliative care needs to be given to these patients, a comfort care needs to patients. And hence it has been care beyond cure, low technology, high touch. You do not require very sophisticated equipments and ICU setups with various equipments, modalities, ventilators, infusion pumps. No, you don't need them. It is just understanding the patient's requirement and providing them support. And usually we say that they don't provide so many of high advanced equipments. What they require is your understanding of the patient's need and providing them a comfort care which can easily be provided by your what I can say, the empathy towards these patients, which give them life to days and not days to life. And this is what we want. And in palliative care, if you see sometimes patient is not getting treated properly or is not responding to treatment, we say nothing can be done. No, this is not the right way. At each point, as a palliative care person, we have something which we can do to the patient. We can provide a comfort care to the patient. I agree, we may not be curing the patient, but we have something to make him or her comfortable at each point of their lifetime. So this is what the model is, which I am emphasizing again, that initially we thought active treatment, when it's not possible, the palliative care needs to be given, and finally patient succumbs to death. But now the palliative care is an early integration where the disease focused care is being provided, but the comfort care is also being given. Obviously, if the patient is not responding, the component of palliative care becomes much larger, and the finally patient succumbs to death. But then also we need to provide support to the family systems in the form of bereavement. And that's why palliative care is now early integration for these patients, so that patients remains comfortable. And this is what we need to understand, that this is, you can understand the disease focused care is important for patients, but then a comfort focused care must be given with physical symptom management, along with psychological, social, and spiritual support, hence to provide them a total pain management, not only during their life, but also a comfortable, good death and bereavement to the family members. Now, where can we give the palliative care? It can be given at any place. We do not require a dedicated hospital setting with well-equipped equipments, monitoring system. No, it can be given at any place, home, hospice, hospital, OPD. It just needs your understanding. And home care is usually considered best, especially for the end-of-life care patients, because it has been seen that patient who is terminally ill wants to be with the family members rather than isolated into an ICU on all the machines and mechanics. And this is what is required for most of the patients. But as a palliative care person, what we can do is we can communicate clearly what is required by the patient, what is need of the patient, and give them a good coordinated care for these patients and support them nicely, providing a good teamwork so that the patient at this point of time is nicely managed among the family members in a comfortable position. And sometimes for this, we need to understand that if a patient is terminally ill, we need to understand that certain things are not required for the patient. For example, say doing CPR on these patients, putting them on ventilators, putting them on dialysis, putting them on high dose drugs for maintaining the blood pressures, or giving them a total parental nutrition, because they will not be required for a patient who is terminally ill, and we know that he is going to succumb. So why we want to increase the agony? So at some point of time, we need to understand that certain things which are not helping these patients must not be given to these patients just to prolong life in agony. What we need to do is provide them a good prevention of total suffering and the symptom management. That is what is required. So thus, the palliative medicine is having a huge scope. It is not a specialized field. It can be given to any patients of chronic disease at any age, at any point of time. Not only, I said, terminal illness, at any point of time of their treatment modality, in any setting and any place. I just mentioned about it. And also the most important is it can be given by any person who has the understanding of the palliative care across specialty, and nursing professionals are one of them. And when it is involved, we provide these patients a affirmed life, promotes quality to these patients, try to treat the patient and support the family. And this is what the philosophy is. The task of medicine is to care even when it cannot cure. And this is the basic philosophy. We don't say that nothing can be done for these patients. We always have something to be given to these patients so that they can have comfort, they can have less agony, we can take care of their total suffering, and hence we can improve their quality of life. And not only for patient, and thus for the family members and the community. And what we can do is we can have various options, like, for example, these type of CMEs, the awareness programs. We can create educations. We have the programs for physicians, for nursing professionals to understand them. We need to provide these services at various places, and that's why we need a huge manpower who have the basic understanding of palliative care so that these services can be given to these patients across India. We need to create more public awareness, and probably once the public awareness increases, there will be more demand of it. And I think we need a huge team of people like you who can help these patients to improve the palliative care, to improve the comfort care, to decrease the agony in patients with chronic disease. So to summarize, palliative care is a care, a comfort care, which provides relief from pain and other distressing symptoms. It affirms life and regards dying as a normal process. It is not for hastening or postponing death, but it is what needs to be given them a comfort care with good death. It integrates various domains of care and requires the team approach, and the nursing professionals is one of the important team member for the provision of the palliative care. And you all, with good understanding of the clinical, the communication, the ethical aspects, and with continuity of care, I'm very sure each one of you can provide our patients who are having chronic disease a good comfort care, so that not only the patient have good quality of life, but also the family members. So thank you so much. And I'm sure that this will be helping you to understand the basic need of the palliative care among our patients who are having chronic disease. And each one of you can contribute to a significant amount by just basic understanding of palliative care. Thank you so much.
Thank you, sir, for your depth knowledge and information to share with us.
At the same time, if at all anybody is there to pose any questions on what all sir has talked about, then that will be welcome. Any questions? Otherwise, they can put it on chat as well. If somebody is.
By the time they are Hamza ji, if they are asking questions, can I put a question to them so that they can have a think? So how many you can just type in chat box? How many of you have seen a patient who is crying in agony at the time of terminal illness, and their family members are usually, they are annoyed that the patient in the terminal illness is crying with pain or is uncomfortable? How many of you have seen it? Just write yes or no. I'm sure the next speaker is again a wonderful speaker. So before she comes up, I think you must have seen in the wards patient crying in agony, or patient who you think is going to die is put on ventilator in the ICUs, and the acceptance between them is not acceptable. I think somebody can raise the hands and they can speak on the mic also if they are sitting in the class, I think.
Nobody is responding that way, sir.
I can see it in the chat.
Or they are trying to digest what all have been taught so far.
We can ask the same question. Sheila madam can ask later on.
Yes.
The same question.
Okay. So, sir has talked about everything comprehensively as always. This is the comfort care, person-centric comfort care, and the family has also to be cared, and the social care need as well. And it is as good health, and if the good health and is quality are all ensured, then definitely that good death is also to be ensured for the patients. Not only for the patients, for everybody as well. And the early integration, the necessity of early integration of palliative care into the treatment protocol, so that the patient gets the benefit. That has seen so many cases, just like one patient with us who is the terminally ill patient, but not willing to come to the hospice at all, rather not getting any treatment at home as well. So that misconception about the hospice, misconception about the end of life care, all those kind of things, that also needs to be taken away. Because it's always said that one day even a hospice will be equal to 1 week's lifetime for the patient, that quality. And it's as always said, it's not days to life, but of course it is life to the days left out. And he has already talked about where it is to be done, the palliative care, how it is to be done, then when it is to be done, and who can all do this, because everybody can do it. As it's not only the professionals, but every common man also can do. By the one example I always cite, that if at all we are in the comfort, if we are comfortably sitting in a bus or in a metro, train, whatever maybe, just offer that seat to that person who is on the corner, standing, suffering from cancer or any other disease, and also having his packets of medical reports and all those things, and is standing there on one corner, means just let us provide that seat, offer that seat to the person, and the comfort of that 15 minutes we can avoid and give to them. So there also we can start the palliative care, if you are not a professional, if you are not a known to the palliative care nitty-gritties. And at the same time, just like yesterday we were there with one patient. I mean, the last fifth patient whom we met was one port spine paraplegic patient. Over the years, he is about now it's more than 10 years he is paraplegic, and at the age of 26 or so, he has got the disease and became paraplegic, and now it is he's of 36 years old, and all the brothers have got married. Till a few years earlier, everybody was caring him, but now everybody has got their own family, and now there is nobody to care him. So over the years, it is not only that terminal ill, it's a prolonged stage. I'll not say that he is a patient as such. He is, of course, he is in that stage because of the spinal issue and the paraplegia, and even the catheter he himself get it inserted. So, and he just says, "Whom I shall ask." Whosoever means it is the years together. No, somebody is on the bed. If we are there on one corner of the house on a bed for even 1 or 2 days, then how we feel, and then we can understand how these kind of people are suffering. So whichever way we talk to them, whichever way deal with them, it all matters a lot to them, because how we speak, how we listen to them, and all these things definitely can be elaborately told by our next speaker, Alice Stella Virginia ma'am, and her introduction, of course, the host will be giving, but this I in every webinar also I speak about ma'am, that that we get a flow of that talk, that delivery of a presentation. It is just like a smooth flow. So that kind of communication, how she is able to communicate, just like Rakesh sir has also said that Stella ma'am, how she gives the presentation. So all these eminent people, just like Rakesh sir, Rakesh sir, Ali Stella ma'am, and next third one is our eminent Professor Dr. A.T. Khora ma'am. So the Sri Swami Samarth College of Nursing and Paramedical Science, Harda, MP, Madhya Pradesh. It is the all of you, the College of Nursing students, you are in the middle of India. You are in the Madhya Pradesh. So if there is awareness among you, then we can expect that it will spread all over India. So you people post the questions. Why do you shy away? Don't make it like a one-way traffic kind of thing. No, it's just like radio. It's only from one side it is coming. There should be a reaction from your side as well. What is palliative care? How it is to be done? Whichever questions you have, you can post, because these eminent personalities every time you will not be getting.
Ministry of Health में finance में
So this is the opportunity, and I think all of you will definitely avail this facility and pose as many questions from the next session, speaker onwards. And I would encourage all of you for this. So please, the host may please introduce Alistella Virginia, ma'am. You're mute, ma'am.
We can, thank you, sir. Thank you so much. We cannot change the outcome, but we can affect the journey. And with these lines, I introduce with you all our next speakers, respected Mrs. Alice Ma'am, Stella Virginia, examiners, National Faculty, IAPC, ELNEC Master Facilitator, has over 36 years of experience in nursing. She initially trained as a nurse in the armed forces at the military hospital, Secunderabad and Jhansi, being commissioned as a lieutenant in 1986. She undertook a national fellowship in palliative nursing in 2015-2016 and is a trainer for both the ELNEC and EPEC courses. In 2019-2020, she was awarded an international award for excellence and leadership in palliative nursing. Within India, she has presented regularly at the Indian Association of Palliative Care Conference. Her many achievements within palliative care include the completion of the modified manual for the basic certificate courses in palliative nursing. I request ma'am to share her knowledge with us.
So thank you all so much, and welcome for my session. So before that, a small correction. Mrs. Alistella Virginia, my spelling is not EA, and comes as IA. And I am not an additional professor of IRCH. I have never worked in AIMS Delhi also. Okay, so I saw it, so maybe people will take it in a wrong way. I finally, last my work was, I am a retired nursing officer from Army also, and also in the state government of Kerala. My final, this one was from Calicut Medical College here in Calicut. Okay, thank you.
Sorry, ma'am.
No, it's okay. I just want to say, because we have put it live, so somebody sees means they will, you know about that.
It is copy paste issue, ma'am, I think. It's okay.
Host disable participant screen sharing. Can I want to share my, please enable. Is it done? Because I'm not able to share. It is still showing the same thing.
Stella.
Yeah, Stella.
You can share now.
Yeah, thank you. Can you see my screen? Is it visible?
Yes, ma'am.
Yes, ma'am.
Okay, so my session is communication skills in palliative care. I would just like to ask the audience who are present here, can you just tell me when we communicate, how do we communicate? In what all way we can communicate? You can just put it in the chat box. Usually how we communicate? Any answer in the chat box? Hello? I hope you all are listening to me. I just asked a question. How do we communicate? What are the ways of communication we use usually? No response in the chat box?
Ma'am, there is no response. Is there any issue for others to give put it in chat box and all? Host may please see, because nobody is putting anything in the chat box.
Yeah. Okay, anyhow, I'll go forward, but please look into that. So what is communication? As you all know, communication is just sharing the information with others. Maybe we can say our ideas or feelings or whatever it is. Just it is a sharing between two or more people on a common background. And how do we share? Verbal and non-verbal. And it is said that more than 70% of our communication takes place through non-verbal means, which we don't realize. Many times we do realize when once after everything has happened, then we go back, then we sit and think, oh, I must have not talked like that. It was from my side, it was a wrong way to communicate with that person so and so way. That's why this all problem arised. Okay. So remember one thing. We talk very less, but our expressions, our body languages actually shows many things before we start speaking to someone. Okay, so 70% of our communication takes place through non-verbal means. Yeah, thank you. Jinu, Annie, Joseph, and Dev Kumar. They responded actually verbal and non-verbal. Good. So our process of communication when we talk, is it simple or complex? Usually people think, we feel that when we talk, it is very simple. We can talk to anyone. But it's not like that. It is not simple. It is always complex. Why is it complex? Because when we speak to someone else, we don't know what is going inside their mind that time. That's in the thoughts. So it is always complex. Never think that it is very simple, because you cannot look into someone's mind or in the thoughts, what is going on in their thoughts, in their mind. So it is always complex. It's not simple. So before going into that, remember one thing, as a professionals, like maybe we are doctors, nurses, we have a lot of problem when we communicate with the patient and the family. And why we have this all problems is it is very simple. See, upsetting the patient and handling reactions. Many times we don't know how to handle reactions. Like suddenly the patient starts crying, the family starts crying, otherwise they are very angry. We don't know how to handle that reactions. And moreover, sometimes we feel that we will upset the patient by telling them about their diagnosis, otherwise their prognosis. And why should I take the blame? So it's better to keep quiet. And one more problem is We do not have that knowledge and the skill. Skill in the sense, the skill of communicating a breaking bad news, or the skill of how to handle reactions. And in the same thing, many times we feel that how to say, I don't know. I usually come across when some people, recently also I was just telling, whenever there is some problem in their house, because I keep taking a lot of sessions. So people directly send all the, the scan reports and the investigations report, everything they send it to me. And then they ask whether I should go for chemotherapy, what is the real problem with my scan and rest of the things. And many times I thought of myself, I'm not an oncologist, I'm not a neurosurgeon, but still people are asking me. And why they are asking me these questions? Okay, so what I reply is, I used to say only one thing. I say, exactly, I don't know what it is, but I can find out and tell you. Okay, that is a very simple answer you can give to your patient and the family. If you don't know, just tell them, I don't know, but I can find out and tell you. They are not going to blame or they are not going to laugh at you. They will admit, at least a person said, because we don't have the knowledge of everything what we learn. So we need to admit that. And of course, I agree, we are too busy, especially the government colleges are very, very busy. We don't get a lot of time to spend with our patients because it is flooded. And we concentrate more on physical issues because now you know that palliative care is not only physical, but psychosocial, and spiritual, and of course, a little bit of financial also. Okay, so as professionals, we concentrate more on physical issues. And we need to think also, we cannot make it better. Even after saying everything to the patient and the family, we cannot make it better. So why we need to talk to the patient this much? And of course, the language and the dialect. Okay, so language is a big problem in India because the people from South, they go to North, people come to the South, they don't know their languages. And finally, when they land up in a hospital, it's very difficult for them to convey in their own language to the other person. Okay, so these all things is very difficult for our professionals. And if we sit and think, there are more other problems also as a professional, what we face when we communicate with the patient and family. Now, when we talk about the patients also, same like us, they also have problem is lack of time and privacy. So we can think as a professional also, there is no privacy when we talk to the patient, when we assess the patient, and time also, there is no time. And the patient starts thinking of the family, whether I can tell them other than any physical things. I have a lot of physical problems, but I have some other psychosocial and spiritual problem also. Can I speak to them about these things? What they will think? Maybe if I say I'm not able to sleep in the night and I'm anxious about my, about my disease. Maybe they will feel that I am having some psychological problem and send me to the psychiatrist. Or they may deny management or the treatment. So what they do is they hide it, especially when we take a retropositive patients. They never disclose that they are retropositive when they come to the hospital because they won't get a proper treatment. Afraid of the truth. If I say these are my problems, suppose they say that you are suffering from a cancer or something like that disease, some life-threatening disease, I'm not able to hear about it. I'm afraid of the truth. And of course, many times it happens, once I come to know about my disease, patient starts crying. They don't have control over their emotions. And the biggest problem, you know what it is? It is two things. One is unfamiliarity of the surroundings and the medical speech. We use a lot of medical terms which the patients cannot follow. Speak to the patients in their own language. Come to their platform. They cannot understand, and they cannot understand your bronchoscopy or your endoscopy. They cannot understand what is a if I say like what to say, adenocarcinoma. They don't follow all these things. So you need to speak to the patient and family in their own language. See, breaking bad news, how to break a bad news, that is a separate topic. I'm not going to talk about that. What I mean to say, tell you is, when you talk to the patient, even if you're telling them about the medications itself, please take this capsule or tablets, instead of that, you can say, please, ye dawa khana hai, ye dawa peene ka hai. Just tell them in their own language so that they can understand what you are talking to them. And in a hospital, they are unfamiliar about the surroundings. They don't know where is the laptop, laboratory. They don't know where is the X-ray department. They are unfamiliar of the surroundings. So we need to orient them. Just a very simple thing inside your own ward. Just orient them. This is the nursing station. That is the washroom, and this is where the doctors will be sitting. So in emergency or in anything, just come and contact you. This is very, very important. So what is the need of communication? You can see here, relief of anxiety and better adjustment with the disease process. Once your anxiety is relieved, we will adjust with the disease process. Every person knows about it, that they are suffering from some disease. They come to know about it. But their anxiety is not relieved. They are anxious to know what is wrong with them, because every now and then they are coming to the hospital. Nobody is explaining to them. They're spending a lot of money on their injections, MRs, MRI, CT scan and everything. But no one is explaining to them what is their real problem. So they are anxious about it. Why they are giving so many injections? People all come around, stand on the patient's, surround the patient on their, when they are on the bed. They stand around the patients and they will be talking over the patient, this side and that side. And the patient will be, I'm very sorry, my video is not working. Otherwise, you could have seen what I am showing also. Patient will just lying down and showing the head from this side and that side, because they are talking over. Some are standing on the right side of the patient, some are standing on the left side of the patient. And they will be talking to each other. And the poor patient will be looking at each other, what these people are talking about me. Talk to the patient. Mutual exchange of ideas or feelings. When the need of communication is when we communicate, the patient starts exchanging their feelings. They want to know about our information, about their information. So that is the way, because communication helps in giving the information and taking the information. And with this, what happens? We can give proper guidance and better compliance will be there. For example, when you give a medication, especially for vomiting for a patient, tell the patient before half an hour of your food, please take this medication. Otherwise, what will happen? The patient will have the food and the patient will still keep vomiting. And when you ask the patient will say, yeah, I'm taking the medication after vomiting. There is no use of it. So we need to tell the patient, khana khane ke pehle ye dawa khana hai aapko. So what happens? That is a better compliance. Because you are given a proper guidance to the patient. Involvement of the family. Involve the family when you do something for the patient, especially when you give a back care, when you give a bath to the patient. Please involve the family, ask them to help you so that when they go back home, they know how to do it. Just like how we teach them the Riles tube feeding. In many places, they don't even teach Riles tube feeding. I sometimes feel it because the patient's family doesn't know what all to give. So we need to teach them. And this will reduce isolation. If you involve the family in the caregiving, isolation also will reduce, because many times patients are isolated in their house. They are not allowed to come out of the rooms. And of course, if there is a good communication, there is acceptance and trust also. But if we fail poor symptom control, if we don't communicate with the patient about their problems, they will never adjust with their disease process, and every now and then they'll keep on complaining about their problems. And there will be poor complaints, there will be lack of cooperation, patient won't take the medicine, because what the patient thinks is they will take once the medicine, and if the pain is not reduced, they won't take it. Instead of that, we need to explain to them, this medicine has to be taken every 3 times or every 2 times, whatever it is. Immediately, if you take one medication, your pain will reduce. But keep on taking it accordingly, however it is written, so that your pain will be reduced. And because of these problems, when we don't communicate properly in their own language, a lot of problems are there within the professionals and the patient and the family. Now, when we talk about effective communication, there are the 3 basic principles what we talk, that is unconditional positive regard, genuineness, and empathy. And what is unconditional positive regard? If I could say, I will just say, if any patients come in front of me, maybe a patient is a retropositive patient, CA lung due to smoking, maybe cirrhosis of liver due to alcoholic patients, in what we see in alcoholic patients. Otherwise, maybe the patient is a prisoner or a terrorist, whatever may be. I need to have an unconditional positive regard to the patient because he has come to me with his problems. Maybe he's a retropositive, but that doesn't matter. For me now, he has a lot of problems and I need to see that. So please don't judge the patient. Genuineness is the truthfulness. Don't lie to the patient. Because tomorrow they will come to know that you have lied to them, that whatever disease they are suffering from. Please don't lie to the patient. There is a way of telling everything. And of course, don't show sympathy. Empathy is better. Why? Empathy is putting yourself in their place. See, try to at least understand what they are going through. Because they are going through a difficult situation. At least you put yourself, if you were in their place, how you could feel. And that is empathy. Because empathy is something that you put your feet on somebody else's shoes. Otherwise, you're putting yourself in somebody else's place. Trying to understand them, what they are going through. And please don't show sympathy. Sympathy doesn't work. So history is something that we are taking the story of a patient. So please listen to the story. See, listening is a skill. Okay. So listen to the patient. I do say God has given us 2 ears and 1 mouth. And you know what we think? We think we have 2 mouths and 1 ear. We hear very less. Please keep listening to the patient and the family, because the key to effective communication is active listening. Listen, listen, listen. Don't talk too much. Let the patient open and talk to you. Let them share their story to you. And whatever you need in that, you just take it out. Just listen to them. They have a lot of psychosocial and spiritual problems which they want to share it with you. They want to just ventilate. Let everything come out. Because at home also nobody is listening to the patient. So they have come to you so that you people can listen to them. And how we can actively listen? In many ways we can listen. Ask open questions to the patient and encourage them talking. Like, how are you today? How are you feeling now? Tell me about your problems. They can share with you physical, psychosocial, any problems. Instead of asking them, how is your pain today? You can ask that question. It's not that if suppose the patient was there with you in and out the past days, you can just ask the patient, yesterday your pain was very severe. Now, how is your pain today? You can ask that question. And encourage the patient encourage talking. Ask the patient, encourage them to talk. And of course, when the patient becomes silent, please do tolerate silence also. It happens that sometimes the patients become very silent. That time, don't disturb the patient because they're trying to, they're trying to recollect something to tell you. And avoid unnecessary interruption. When the patient is talking about the pain, just listen to the patient. Instead of you would like to know about the patient's bowel movement, just don't jump and ask, no, just tell me how is your bowel movement. No, don't interrupt every now and then. Just listen to the patient and show that you are hearing verbal and non-verbal means, like nodding the head. Okay, we can show them that we are hearing. We can summarize and prioritize the agenda also. Whatever the patient has told you, you can say, see, you told me you don't have sleep in the night, you are having pain here and there. These are your complaints. Okay, so whatever the patient has told you, when you summarize, the patient knows that you were hearing the patient verbally and non-verbally. And of course, give realistic hope. Never give a false reassurance to the patient. Patient who is dying and going and telling the patient, you will become all right. And the patient very well knows the patient is dying. There you are lying to the patient. And give realistic hope. A big, cancer wound, it's not going to heal. And how can you go and just tell the patient that you will be all right? The patient is not going to be all right. Instead of that, you can tell the patient, whatever the smell is that the malodor is there in the pain is there, we can reduce that. And that is giving a realistic hope. And of course, our body speaks more than words. Remember this one thing, our posture, our eye contact, our touch, our gestures, pace and tone of voice. Whenever you sit and talk to the patient, just look to the patient. That eye contact should be there, the touch should be there. They feel better when you touch, but only if it is appreciated. If the patient doesn't want you to touch, they will give you a cue for that. Okay, they will avoid it. After that, just don't touch the patient. And remember, when you talk, just keep a watch on your tone of voice also. And the barriers, a lot of barriers are there. Some might be pretending busy, like looking in the watch, looking outside, very busy with the mobile phones and all. This all, we are pretending very busy. And concentrating on physical issues, not talking to the patient about their psychosocial problems. Don't give false reassurance. Talking in the medical language is a barrier. Showing sympathy is a barrier. Comparison. Please don't compare the patients. One patient and the other patient. Please don't compare. They all are not the same. If there are 10 patients with a pressure ulcer, 10 patients are different. They have different problems. You cannot plan the same thing for all the 10 patients. No. Same thing you cannot compare also. Maybe a patient who is having a pressure ulcer, he can tolerate the pain. But just showing that patient is saying, see how he's tolerating the pain and you are having a very small injury only. No, you cannot. So don't please compare the patient. Patient can compare with others. They can compare. They can say, I'm far better than that other patient. That the patient can do. And communication. Communication is best learned through experience. You all may be in the, now in your, this is what to say, in your nursing, you all must be nursing students. Some may be already the, this one qualified nurses will be there. but still you are also on the way of experience. Best learn through experience. You can learn from your juniors, you can learn from your seniors, you can learn from everyone, but take only the good things. Whatever you learn, take the good things from others. Identify your skills and try to refine them. In the sense, when you talk, just find out whether I talk very fast. You can ask your friends also, do I always communicate very fast? Do I lose my temper very soon? You can ask them. And if you feel that you talk very fast, sometimes you use a lot of medical terms, try to refine them, try to use that very less. And identify your shortcomings and try to overcome them also, like especially anger. If you lose your temper very fast, please to identify them. And the best people to identify is who is on your left and right. Your friends, your colleagues who are working with you. You can ask them about yourself. And for communication, there are no fixed guidelines. And never, please, it should be always patient-centered and the context-oriented. Whatever is going through the patient, please, it should be patient-centered. What the patient is having, that problems. Don't go out of the text. And please never try to imitate others. I can't become Amitabh Bachchan. I cannot talk like an Amitabh Bachchan or Shah Rukh Khan. Okay. If I start imitating them like them, everything will go upside down. So never try to imitate others. Learn from others, but don't imitate. You should have your own way of communication style. And with this, I stop my slide. And if you have any questions, you can just share it or ask.
Thank you, ma'am,
Thank you very much, ma'am,
for your innovative information which help nurses to give palliative care of patients. Thank you, ma'am. Thank you so much.
Welcome, welcome.
Any questions coming up? Not all are on YouTube, no? It's about 49 participants are there. Nothing is coming up.
All the participants can ask the questions.
Okay, ma'am, I think if no question is coming up, then we shall so to the next. Before that, to sum up, whatever the Alistella Virginia ma'am has talked about, it is the communication and the language, dialect, everything matters. And ma'am has already talked about verbal, non-verbal communications and observing the patients, talking to the patient, talking over the patients, which definitely needs to be avoided, and empowering the patient, and all these kind of things, especially the anxiety the patient is going through. And for this, ma'am has given the remedy also, that is the listening. The listening skill, developing the listening skill, and the basic principles of that unconditional positive regard, genuineness, empathy, and all. Because as ma'am said, and at the same time, I will also say that our Lord Ganesha is always with the two big ears, and he removes the obstacles, so-called Vigneshwara. So that is the basic principle actually. Unless you listen, you cannot improve the quality of life of that very particular patient. And it is really true that how your body language is. The patient is observing you, and whatever the slightest body language, even you're seeing your watch, or you're again and again picking the mobile and seeing it, that also gives a very bad distraction for the patient to open up. So it is always the communication that really matters. So ma'am has very efficiently put all the points together and delivered her lecture in the best possible manner, as always. And it's a pleasure listening to her. We never get bored on that, on the communication at all, because we learn every day. We learn new things from ma'am. Thank you so much, ma'am, for your supporting us, the Delights National Initiative in Palliative Care, DNIP Care. We are a small organization, but at the same time trying to reach out to all, one and all. And it's a real great thing that the Nursing Scholar Society, with hardly 2 years of since its inception, it has come up in a big way and offered to put across this mission of palliative care to the masses. So from this Delights National Initiative in Palliative Care started way back in 2008 by few of us, and today in comparison to the other organizations and all, we don't have much statistics to boast about or to speak about, but to that patient, one patient whom we care, that matters to him. That is our basic thing, and that way we go to each and every patient who come across. And we have our palliative OP clinic on every Sunday, and in that we are functioning with listening desk also, where psychology students, psychology master students, psychology PhD holders, they all come and sit so that the patients can hear, patients can be heard. So that is the way the listening desk work. So it's a real pleasure that all the eminent people are there to bank upon for us in the palliative care, in the improving the quality of life of the patients. So next speaker is Professor Dr. A.T. Khora ma'am, and she will be talking about the role of nurses. And with her experience, extensive knowledge and experience, and she is the Florence Nightingale awardee also, and the same way, just like our secretary Mr. Suresh TP is there. He is the one and only Florence Nightingale's awardee, that too male nursing officer from Safdarjung Hospital so far. So he is the real backbone behind the all these sessions, all these organizing all these propagation programs for nursing students, for common people and all. He coordinates all these things silently, though never he comes up on the screen. So just like him, A.T. Khora ma'am, with her the experience and in the Delhi as well as in Purnia and all everywhere, she will be able to deliver the real crux of what the nurses are supposed to do and what the further prospects are there for nurses by entering into this arena of palliative care, which is the true human care. So thank you, Stella ma'am, and welcome to T. Kora ma'am, and the host will be introducing her. Please.
Thank you, sir. Compassion is the wish to see others free from suffering. With these lines, I am going to introduce the person, great nursing iconic personality, respected Dr. A.T. Kora ma'am, who is principal NIINS Purnia, Bihar, completed MSc Nursing Psychiatric MPhil in Counseling and Guidance, PhD was Nursing Superintendent at St. Stephen's Hospital, Delhi. She is professor at St. Stephen's College of Nursing. She was evaluator of nursing at Dukkan Hospital, Rexall, Bihar. She is a nursing service committee chairperson of TNAI, Delhi, branch program coordinator of DNA program of IGNOU. Awards receive TNAI Award, National Florence Nightingale Nurses Award, etc. I request ma'am to take the session. Over to you, ma'am.
Thank you all for the introduction, what you have given, Mr. Hamza, and the host who have introduced me. Good afternoon to one and all who are listening to me. It was a great pleasure to listen to Pitikol ma'am, Rita ma'am, and Alka ma'am initially, and then to the eminent speakers, Dr. Rakesh and Alistella ma'am. Now, the topic for me to talk today is nurses' role in palliative care. From all the talk, you might have come across many of the things what a nurse is supposed to do. Can I have the slides, please? Can I have the next slide, please?
Yes, ma'am. Yes, ma'am.
When we say palliative care, what do we mean by palliative care? This was already discussed by Aristella ma'am and Dr. Rakesh. When we say the active total care of patients with an incurable, progressive, life-threatening condition and their families by a multi-professional team. That means, slide please.
Yes, ma'am.
The active total care of patients with incurable, progressive, life-threatening condition. Other than cancer, there are so many conditions in which a patient and family needs supportive care. Say, for example, a person with MDR, a person who had stroke, a person who is having a cardiac disease. In all that, they see much of gray areas and the family needs more support because the person is going through a life-threatening condition. A nurse alone won't be able to give the care to the patient and the family. Thus, we need a multi-professional team. Next slide, please. The goal of, next slide, please. The goal of palliative care is to achieving the best quality of life for the patient and family. How can we help the patient to achieve the quality of life? What will be the limitation? What will be the sickness what the person is having? We are there to help the patient to have the best what we can give to the patient. Thus, we are able to help the patient's family also to cope up with the situation. Next slide. The nurse's role is the unique opportunity to maintain patients and families' hope by providing excellent physical, psychological, social, and spiritual care. Unique opportunity a person gets. Who gets it? Nurse. And a nurse is a person who is going to deal with the patient and the family. Next slide, please. When you say palliative care, the total care of patients in which physical care, social care, psychological care, and the spiritual care is given. Physical well-being, and we say, next slide, functional ability. The person may have certain limitations. A person who used to do all the work suddenly see that he cannot do all the work that he used to do. He may feel that he's not having enough strength. He may feel excessive fatigue. He may feel he needs to sleep more and more. He lacks rest. All this the person experiences. Person may experience nausea, may have loss of appetite, may have constipation, may have severe pains. All these are the things what the person experiences physically. And family may get very upset when the patient is saying, cannot eat. They may say, a person who used to eat so well, suddenly he is telling he can't eat. Mujhe bhook nahi hai. That's a common term what the patients say. So when the patient's family is getting upset with the thing, we are there to help them to cross that particular difficulty. How can we help them to cross? Many a times with the psychological well-being attention and the social well-being attention, what we can extend to the patient and the family, we are able to help them. Next slide. Yes, psychological well-being. When we say psychological well-being, the person may have loss and change of role, loss of many things what the patient used to have. Patient may have various experiences. Person may be feeling that he cannot do anything as his own. He loses his independence and control. He may not be able to do the things independently as he used to do. He may lose hope for the future. I'm down with a sickness in which I may not come out. In such a situation, when the person is going through the difficulty, he may not have hope for the future. Loss of employment. If the person is very sick, he may not be able to do the work, and he may lose the place in the family as the head of the family or as the breadwinner of the family. And when a person is going through these losses, he finds it very difficult to adjust himself. Marked responses seen at various points in cancer patients, especially when they are experiencing all those losses. One specific thing what a person experiences, losing his position as head of the family. Many a times we say, if you are not there, others are there to take care of the family. Easy for a nurse to say that, but very difficult for a patient to experience it. Why I'm telling it's very difficult for a patient to experience it? Because that patient may be the only breadwinner of the family. Patient may be the one who is earning and taking care of his parents, his wife, his children. And suddenly, when he is in bed, he sees that there's nobody to look up to. Many a times, I have come across the situations in which patient says, मेरे बच्चे सारे छोटे हैं, मैं चले जाएंगे तो मेरे बच्चों को कौन देखभाल करेगा? That is a question which many patients do have. Even a mother who is taking care of the children do ask this question to the caretakers. A mother who is taking care of the children feel without her, the children will be left behind. There's nobody to meet the needs of the children. So if a patient is having cancer, when it is diagnosed, the person may feel it's not acceptable. At the time of diagnosis, And soon after, how can this happen to me? No, doctors are making some mistake. One person may say that they may go from one doctor to another because they feel the diagnosis what this doctor has made is not correct. So they go to another hospital. Then treatment is taken. Patient is on the road to recovery. Suddenly, patient comes up with some problem and you are diagnosing that there is a recurrence. Patient finds it very difficult to take it up. I still remember when one of our doctors were told, you are having secondaries. Her immediate question was, I won't be able to celebrate my daughter's birthday anymore. She is having only one daughter. But when she had the first recurrence, this was her question. Thank God, now also she is alive. She had gone through a lot of pains and aches, but having herself by the side of her daughter was her aim. And she struggled. She was confident enough to come out of the sickness for her daughter. As function declines, when a patient with cancer, if his ability to do the work is going off, if he is not feeling hungry, if he is not able to eat well, he gets worried. There will be variation in his responses. And finally, when the death approaches, when the person is very sick and when the person is hospitalized, he finds it very difficult to take it up. Why? Because he knows that, he or she knows that there's nothing to look forward to. Next slide, please. The spiritual well-being. When we say the spiritual well-being, the person is having various questions to his own self. He starts finding meaning to his own life. Why are we here? What for I'm here? That is a question often patients do ask. Becoming, who am I? Where am I? Why am here? Connecting. Who are we? Each other. Then transcending beyond the senses. The common spiritual concerns are, the next slide, please. Personal identity. Person start identifying himself as a person who cannot go forward with what he or she is having. Meaning of suffering and pain. The patient start looking out for meaning of suffering and meaning of pain. Meaning of life, his value systems, questions God, why God is giving such a situation for me. Have I done anything wrong? Why this punishment is given? That is often the question. Guilt feeling. I might have done something wrong. That may be the reason why God is giving me this. Then, when he knows that he is going to face death, he starts thinking about life after death. Next slide, please. Here I have put a patient who is on ventilator. Now, working with a sick person, I have titled it. The reason is we talk about taking care of the family when the patient is sick. When the patient is on ventilator, the patient's family and the patient go through a lot of struggle. If we are there to support the patient's family and the patient, that will be taking them through the difficult situation in an easy way. Next slide. Here you will be able to see that patient is better out of ventilator and patient's son is there showing her some pictures, some photos of her grandchildren, and patient is with a smile. Next slide. Here, the patient is sitting up out of ventilator. She's having a tracheostomy, and a T-piece is connected to the tracheostomy. Now, walking with a sick person is to be done not only when a patient is on ventilator, other situations also. I remember a patient who was in the renal failure. Patient's family, patient's wife is a teacher. As she is a headmistress of the teacher, she had to go for work. But after the school, she used to come to the hospital, stay with the patient. When his restrictions on fluid intake is told to him, his reaction was totally different. When he is irritated, he used to shout at his wife. So the psychological care, what we talk is, more than the patient, the family was needing it. Wife stays with the patient right from the evening till the next day morning. And she was practically living in the hospital. Patient, being a stubborn patient, he wanted to do the things in his own way. That was not permitted. He started taking plenty of fluids. He started taking food which was not permitted to him. Outcome, family was going through the pain. And when we talk about the social situation for that patient, when we made him to sit out on a wheelchair, all the passers-by used to go and ask him, "How are you?" One day, I was standing behind him and listening to him. Another patient's relative came and asked him, "How are you?" His reaction was, "जब मैं पलंग में है, तब कोई नहीं आता, कोई नहीं पूछता. जब हम बाहर बैठे तो सब लोग आके पूछते हैं." So, as Alice Stella ma'am was talking about communication, everything what is happening, every sentence, every touch, every situation what we are creating for the patient makes a difference. Next slide, please. The essential components of palliative care is hope, honesty, and openness. That is psychological support, the symptom relief, teamwork, and partnership. The palliative care, next slide, is patient-centered care, partnership between the patient and carers, focused on healing rather than curing, death accepting, but also life enhancing. Many a times, making the person to prepare for accepting all this is not an easy thing. Next slide. The palliative care can be extended either as home care, which is the best and the easiest way, medical consultations, medical outpatient clinics. Nowadays, in many of the hospitals, you can see the OPDs are having pain and palliative clinics. Daycare, inpatient care, that is, many patients are admitted in various departments, maybe in surgery, maybe in pediatrics, maybe in medicine, and they are being cared in that particular area. Bereavement support, when you know that the patient is not going to make it, you are not able to make the patient to come out of that situation, you are preparing the family and the patient. Hospice care, and these are the various ways by which a nurse can extend the palliative care. When you are breaking the bad news Your facial expression is something what the patient look at. Once, when a patient was there and I was there with the patient came out of the doctor's consultation room. Patient's son was there. So patient asked me, "It is cancer only, no?" Patient was looking at my face. Son was looking at my face. I didn't say anything other than shaking my head. The son burst into tears. Patient burst into tears. I couldn't tell them, "Don't cry." I was just touching the shoulder of the patient and staying with her. So many a times you see such difficult situation in which you may not know how to respond, you may not know how to react, but your physical presence there makes lot of difference for the family and other members. On 22nd of this month, I lost one of my old students who was suffering from cancer. She was diagnosed as a cancer patient 2 years back. And on 22nd of this month, we lost her. Many a times when you stay with the family, when a near and dear one passes away, it becomes very difficult. But being a nurse, you have to stay there with a grieving family. The grief reactions may vary, but you will have to stay with the patient, with the relatives, the family members, and help them out. With this, I close my talk. So any questions you can put up. Otherwise, thank you all for the patient listening.
Thank you very much, ma'am.
Most welcome.
Is the psychological issues, physical, psychological, and social well-being, everything has been touched upon by you. And of course, hope, honesty, and openness. That's the real crux of it when we are dealing with the patients. So anybody is posing any questions? Chat was active, or everybody is busy in post session questionnaire? Somebody should respond. Participants.
Excellent session.
That's nice. Thank you.
Thank you, ma'am.
Nice.
And apart from that, because it is it is the way how we put it, no? Just like after all, the nurses, the budding nurses and the nursing professionals, your dying patient is my living father or my living parent or my living relative. So that's it. So it's every time it is that sensitivity that matters a lot. That is already been talked about by all the three speakers plus the dignitaries, Viti Kaul ma'am, Rita Sharma ma'am, Alkata Isna ma'am, all are there and emphasizing on how it has to be done. Okay, somebody is writing valuable session. That's nice. That's good response. But the thing is that we should not have left these speakers simply that way. We could have posed so many questions. It is a chance. Okay, it was nice. So we are again really grateful to Nursing Scholar Society for facilitating this, and Sri Swami Samath College of Nursing and Paramedical Science, Harda, Madhya Pradesh, for conducting the session, and all their budding nurses, nursing professionals and faculties, everybody being present and giving support and support for this initiative, so that let us have the, as I always say, let us have the carpet bombing kind of propagation of palliative care to the masses. Unless we do that, we do not know when is our time. So let us just like that time bank, let us give energy and time today, so that tomorrow when it is required even for us, that should be there, that everybody should be covered under this ambit of palliative care. So it was a very good, well organized program today, this virtual webinar. And now I think the host will be putting others to speak. Please.
Thank you so much, ma'am. We are lucky for your presence at our session and gain knowledge given by you. Now I move to next part of our session, question answer session. All the participants must fill the post-test form. All the participants fill the post-test form. Gratitude makes sense of our past, bring peace for today, and creates a vision for tomorrow. These lines express gratitude for all the people and guests who give their valuable presence. I invite our respected director, Dr. Arjun Mohe sir, who is journal and laparoscopic surgeon at City Hospital Harda, and also the director, Sri Swami Samath College of Nursing Harda. He has done his MBBS in year 2006 from MGM Medical College Indore. Sir has done PG from MGM Medical College Indore in year 2009. Sir has joined District Hospital for 2 years. Later, he had joined City Hospital in year 2011 till date. I request sir to give vote.
Dr. Sir, I think you are muted. Unmute, sir.
So you are muted.
I request to give
I request Dr. Arun sir to please change the background. There is so much sound in the background. Dr. Mohi sir, please change your place.
Good afternoon to all respected fraternities. It's a great honor and privilege for me to express gratitude. I, Dr. Arjun Singh Mohe, General Laparoscopic Surgeon, City Hospital, Agra, and Director, Sri Swami Samarth College of Nursing and Paramedical Sciences. Heartily thanks to all. I heartily thanks to DDP Care and Nursing Scholar Society for providing this facility to organize this virtual conference in our institute. I heartily thanks to our dear nursing SGT University for inaugurating this program in her busy schedule. Thank you, ma'am. I express my sincere gratitude to our guest of honor, Mrs. Rita Sharma, ma'am, Chief Nursing Officer, M. Rishikesh. Thank you, ma'am, for your valuable time. I give my sincere thanks to Dr. Alka Tajne, ma'am, guest of honor of our today's session. Thank you, ma'am. I express my gratitude to our today's session moderator, Mr. K.V. Hamza sir, General Secretary, DDP Care, to make this session more knowledgeable and interesting. Eminent speakers. I thanks to Dr. Rakesh Garg sir to share his great knowledge and information with us about need of palliative care. I express my gratitude to Mrs. Alice Stella ma'am, share her depth of knowledge and information on communication skill with us. Thank you, ma'am. I express my sincere thanks to Dr. A.T. Kora ma'am to reflect her light of knowledge on nurses' role in palliative care. Thank you so much, ma'am. I would like to express my sincere thanks to General Secretary of DDP Care, Mr. Suresh sir, to organize this great session with full of joy information. I lastly thanks to all of the organizing team, faculty, staff of computer operating system to make this event successful. Not the least, the last, I thank all the delegates to give your valuable presence. And I congratulate to Nursing Scholar Society on our second anniversary. Congratulations to all. Merry Christmas to all and Happy New Year. Have a good day ahead. Thank you so much. Sir, thank you so much, sir.
Thank you so much, sir.
Thank you. Thank you. Really great experience.
I request to participant to fill the post-test form. Certificate will be given to those only who fill the post-test form. Now session is over.
Thank you.
Hello. Nice.
Thank you, Hamza sir. And thank you, Suresh sir. Looking forward